Great. Again, thanks for the opportunity to present to this group on the future of clinical research in cervical cancer treatment. My name is Charles Kunos. I'm at the University of Kentucky Markey Cancer Center. I too, like Julie, am a radiation oncologist in the Department of Radiation Medicine. For this particular talk, I have nothing to disclose, except I was a former government employee, so the views expressed are my own as a former K-12 trained scholar and not those of the University of Kentucky or the US federal government. Links or discussion of any specific drug products does not constitute any endorsement. If I can get the next slide. So I want to spend some time talking about uterine cervix cancer treatment as a national priority. Certainly this disease and the treatments that are utilized in this disease are not fish out of water. I have four areas of topic to discuss today. One is on the advanced stage uterine cervix cancer survival rate has not risen in 2 decades. We've heard a little bit of information about this before. I'll hit some of the highlights there again. Second, radiotherapy utilization drives survival for advanced stage disease. Third, intensifying regional treatment improves survival. And four, identifying women at risk for distant disease relapse impacts survival outcome. If I can get the next slide. So let's get started with the first topic. If I can get the next slide. Radiotherapy as a cancer treatment remains an effective option for patient cure and for palliation. It helps cure some diseases such as localized breast cancer, cervix cancer, and prostate cancer. It provides long-lasting palliation and control of many others. More than 17.9 million American pediatric and adult cancer survivors are estimated to be alive as of November 1st, 2021, half of whom have received radiation therapy as part of their treatment at one time or another. Steady federal support of practice-altering basic science and clinical research ultimately has translated into enhanced cures and reduced mortality and morbidity from these diseases. New insights in cancer biology, radiobiology, and radiochemistry have repositioned radiotherapy at the leading edge of personalized medicine oncology research, as my previous colleagues have demonstrated. Uterine cervix cancer is clinically, molecularly, and genetically heterogeneous as a human disease, which makes it very challenging to discover effective personalized medical therapies. Although mortality due to uterine cervix cancer in the United States has decreased, more than 4,250 women still die from this disease each year. If I can get the next slide. We've seen this graphic before, but this is the SEER survival estimates from 1992 to 2018. And you can see that over time, there has been a decrease both in the incidence of the disease and the mortality from this disease in the surveillance and epidemiology and end results databases. But I would suggest that more emphasis needs to be placed on those who actually have the disease and are diagnosed with uterine cervix cancer, since the mortality really hasn't changed in the last 2 decades. Opportunities to understand the biology, therapies that modify drivers of this disease, and best practices for post-therapy surveillance are evident and need to be exploited. If I can get the next slide. This is again data from the SEER registry database, but you can see depicted in the upper graph that uterine cervix cancer by cancer stage cluster demonstrates that about 52% of the disease at presentation is either regionally spread to lymph nodes or distantly spread to other organs. That translates in the lower panel to a lower 5-year relative survival. Again, you can see there's a precipitous drop from localized disease where cure rates can approach 92% to only 50% in regional disease or 18% when the disease is distant. And so certainly there are treatment recommendations that are guided by these types of disease presentations. And so these data certainly influence current and future treatment research. If I can get the next slide. Depicted here is uterine cervix cancer incidence as recorded by the 2021 Geographic Information Science Portal for Cancer Research. This specifically evaluates cervix cancer incidence per 100,000. It's interesting to consider that in Appalachia, extending from New York to Alabama, consists of 410 counties in 13 states, encompassing approximately 22 million Americans, or about 8% of the total American population, and that cervical cancer tracks relatively closely to this distribution. Death from uterine cervix cancer disease occurs within 1 year in about 4 of every 11 Appalachian women diagnosed. outpacing mortality in most elsewhere in the United States. I'd like to repeat that. 4 of every 11 women residing in an Appalachian county, or 36%, diagnosed with cervical cancer dies within 1 year of diagnosis. There are certainly many factors that contribute to this mortality, but it's alarming that this still occurs in 2021. If I can get the next slide. We've seen this presented several different ways, but the total project dollars spent on cervix cancer in 2021 by the NIH is relatively diverse across the United States. It's interesting to note that in states where the cervical cancer incidence is the highest, such as West Virginia and Kentucky, research spending is relatively the lowest. Certainly, there are areas to improve, and this encompasses, projects of all types, from the entire disease spectrum of surveillance and prevention through treatment. But I think research dollar allocation could be better spent looking at areas where the disease is most prevalent and where the mortality is the highest. If I can get the next slide. I'm going to focus a little bit on Kentucky because the Commonwealth of Kentucky has the highest death rate per 100,000 women for cervix cancer in the contiguous 48 states. If you look at the distribution of cervix cancer incidence as well as mortality, you can see that the counties to the furthest east, or those that are residing in Appalachia, have the highest death rates. And those can be upwards of 3 times the national averages for the disease. And so identifying how socioeconomic factors as well as disease related factors contribute to the outcome of patients is important. Preliminary research here at the University of Kentucky identifies that HPV-31 is one of the significant drivers of adenocarcinomas of the cervix in this region, and is a high contributor of early mortality from the disease. If I can get the next slide. I'm going to move on to the second topic just because it's interesting, and we've heard some information from Julie about this, but radiotherapy utilization certainly drives survival for advanced stage disease. If I can get the next slide. As Julie pointed out, daily or teletherapy or treatment from a treatment machine external to the body is given for patients with cervix cancer. It's usually a treatment that's once a day, Monday through Fridays, no Saturdays and Sundays, for a period of 5 weeks. Whether or not these types of courses will remain the mainstay of cervical cancer treatment for radiotherapy, or with improved technologies, as Julie talked about, we can reduce that to maybe a fewer number of weeks of treatments, remains to be determined in clinical trials. If I can get the next slide. Brachytherapy, some would consider, is the most important component of radiation treatment for cervix cancer. Currently, 5 high-dose rate brachytherapy treatments is the most commonly used treatment for this. This is a picture of an applicator resting next to a uterine cervix cancer. And again, it's hard to argue that changing this form of radiotherapy will be met with much success because it is so good at delivering high doses to tumor. But whether or not we can integrate this with a shorter course of external beam radiation therapy is yet to be determined. If I can get the next slide. Certainly, weekly cisplatin chemotherapy is critical in the management of uterine cervix cancer. Currently, this is given once a week, most typically for patients, but whether or not cisplatin is the best drug or best radiation sensitizer is yet to be determined. There are newer agents that are being tested in combination with cisplatin, or perhaps without cisplatin in the future, that might be better to utilize than the current regimen. If I can get the next slide. I think really an exciting area of development that is currently being investigated is radiopharmaceutical therapy. As this group knows, teletherapy treats through normal tissue to deposit radiation dose for cancer cell kill. Radiopharmaceuticals are radioactive drugs with cell targeting capacity so that normal cells and tissues are not irradiated. These agents are currently under investigation at the NCI's Cancer Therapy Evaluation Program. Preliminary work in uterine cervix cancer is underway at this university as well as others, and in the NCI's Experimental Therapeutics Clinical Trials Network. Therapeutic radiopharmaceuticals are highly specific, have desirable in-residence time at the target, and have favorable elimination characteristics that it ensures optimal tumor to background differentiation. targeted radiopharmaceuticals might be capable of extending radiotherapy dose reach beyond just the local area of disease and reach those regional or distant sites. It is certainly possible that well-targeted radiopharmaceuticals could be used both in the concurrent as well as the adjuvant settings to be applied in clinical trials, and this is something that's under future clinical investigation. If I can get the next slide. Moving on to my third topic, intensifying regional treatment improves survival. If I get the next slide. Certainly, advances have been made in vaccine, surgery, either by hand or by robotics. Radiotherapy, as I've touched on before, could come in many different forms, including external beam, brachytherapy, or radiopharmaceuticals, and other forms of drug therapy. Each of these could be combined to improve cancer outcomes and make access more of a realization for patients that have trouble having access to these therapies currently. If I can get the next slide. One of the interesting areas that is emerging in 2021 is that the NCI's Cancer Therapy Evaluation Program built a patient match platform for the study of antibody drug conjugate therapies. These therapies link the power of tumor selective targeting by antibodies, here colored in blue, with cell lethal drugs, here colored in yellow, that potentially reduce injury to normal cells for lower side effect profiles. A predictive enrichment trial study design perhaps offers a greater chance of therapeutic success through high likelihood of response to therapy. And these are exciting opportunities that will be emerging in the clinic in the next few years. If I can get the next slide. As I mentioned, beginning in 2022 and over the next decade, we should see the NCI's Cancer Therapy Evaluation Program continue to build patient-matched platforms for the study of antibody radiopharmaceutical conjugate therapies. Here, cancer cells in pink are targeted by either antibodies or proteins in green that can selectively kill cancer cells and not irradiate normal tissues. Certainly, radiopharmaceutical research so far has led to 3 FDA approvals for treatment of cancer, with more on the way. A prognostic enrichment trial study design perhaps offers selection of patients with high risk of poor outcomes for treatment with radiopharmaceuticals. If I can get the next slide. I think we're going to be seeing more investigator-initiated NCI Cancer Therapy Evaluation Program trial designs that will offer personalized dose intensification. These are the types of trials that the federal government is particularly in a strong position to support because of the personalized medicine approaches they have already with oncogenetics and perhaps dose intensification based on other tumor characteristics. If I can get the next slide. I also think, as I mentioned before, that investigator-initiated and NCI Cancer Therapy Evaluation Program trial designs will perhaps offer schedule intensification. So this is shortening the external beam radiation dose so that patients where there are socioeconomic limitations of the underserved and minority groups will drive research to evaluate shorter courses of frontline radiotherapy. And I think this will happen over the next decade or so. If I can get the next slide. All right, for my last topic. I think there have been exciting developments in the laboratory where pharmacodynamic evaluations might use blood-based assays that inspect the level of DNA damage marked by deoxyribonucleotides shed by dead cancer cells in the blood can be used to optimize schedule and sequence of drug combinations and agent combinations. So perhaps the ability to measure these and put them in quantifiable context will be able to give us more information about whether or not patients have early signs of relapse versus therapeutic success. If I can get the next slide. I think critical inquiries in agent development will involve whether dose and schedule impact efficacy, use of circulating cell-free DNA as a biomarker of radiochemotherapy efficacy might be a predictive biomarker of treatment response. A phase 0 trial detecting whether shed cancer cell or human papillomavirus DNA is found in peripheral blood of uterine cervix cancer patients is still needed, but techniques have been worked out to detect these gene signatures in blood already. If I can get the next slide. I also think that there will be an opportunity for evaluation of circulating tumor cells, which are an unusual subset of cells found in the peripheral blood of subjects with solid tumors like uterine cervix cancer. These cells might see tissue as metastases. Cancer cells metastasize through the bloodstream either as a single migratory cell or perhaps in clusters. And it is unknown whether or not we can detect these in a reliable fashion to predict whether or not therapies will lead to early successes or identify patients who may need additional therapies. If I get the next slide. I also think that the work that Dr. Schwartz has done, on pre-therapy or post-therapy FDG PET scans will become increasingly important. The current phase 3 trial, GY006, is evaluating the use of this type of scanning as a biomarker at 3 months. Is still being evaluated, but I do think that there's going to be more opportunity to use these oncometabolite and assessments of molecular signatures by PET scans will become very important in the next 2 decades. If I get my next slide. Last, I think it bears repeating that Appalachia consists of 410 counties in 13 states of 22 million Americans, or about 8% of the total American population. We've seen that the death rates in these areas are extremely high, and that identifying issues and barriers to those patients receiving treatment is very important. So is it, transportation issues, infusion chair time, multiple biomarker samples, trial complexity, all of these factors, impact clinical trial participation. I think next generation trials need to consider these factors when they're being operationalized and activated. In a state like Kentucky, where 65% of uterine cervix cancer subjects reside outside the catchment area of the primary site of treatment, this is a serious consideration. If I can get the next slide. So hopefully I've, in my allotted time, discussed uterine cervix cancer as a national priority. I've touched on 4 major topics, and I thank you for your attention. I think that was my last slide. Thank you.